So as usual, thank you for joining us today for our education series. Before we get started, I do want to let you all know I'm going to be sharing a link to the regional telehealth survey in the chat and as part of our follow-up email. The purpose of our survey is to gain insight into training needs and feedback on resources to inform on education and outreach opportunities that we can help create best support your telehealth needs. So after the webinar or sometime during this week, if you could please take 10 to 15 minutes to complete the survey, it will be very, very helpful for us. And it's really important that you share your insights and experiences with us as well. So just a few notes as we move into our presentation today. The session is being recorded and we will share it with you afterwards, as we usually do. Please use the chat to ask questions as we are going to have a very large group attending today. If you would like a completion certificate, please contact us at our email and we will be putting that in the chat. Be sure to include your full name as you would like it to appear on the certificate. We do have a lot of information to share today, so I will reiterate, please using the chat. We will be monitoring the questions and we will be saving them for the end of the presentation if we have time to ask them during the webinar. All questions will be documented, however, and shared in our follow-up email if we don't get a chance to have them answered during our time today. We will share them in the form that we typically do as part of our follow-up email. So let's get started. I'd like to introduce our speaker, Rochelle Marting. Rochelle is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing, and reimbursement, HIPAA privacy and security, health information management, and regulatory compliance. We're very fortunate to have her with us today to go over all of the things to expect in 2025. So now I will turn it over to Rochelle.
Okay, thanks, Molly. Well, since our last discussion, and I believe it was November, and we were talking about changes to the physician fee schedule for 2025, you'll have to catch me as I'm saying my dates because I'm still getting used to saying 2025 instead of 2024. So I'm going to try to be extra careful today as we talk about some of the changes that are happening with telehealth as of January 1, some upcoming important deadlines, and kind of what to think or what to expect with telehealth in 2025 and beyond. When we last touched base, we talked about the 2025 Medicare physician fee schedule and some policies that CMS has within their authority to review and promulgate as rules in terms of telehealth coding and billing and payment rules. That was really important because it came late in November, just as we were heading to the end of 2024. And there were some really important pieces of telehealth policy that made December 31st, 2024 a very significant date. And down to the wire, 24, 48, 72 hours before the end of 2024, we had some legislation that saved a host of different telehealth policies that would have otherwise expired January 1 of 2025. So we're going to revisit what some of those policies were, the significance of that December 31, 2024 date, and where those policies stand today and where they might stand in just a few short weeks. Since we've talked last, one of the biggest changes has been the change in federal administration. So we're going to look at some of the policies of the new administration, some of the activities we're already seeing now that the inauguration has occurred, to kind of get a glimpse of what telehealth policy might look like in 2025 and beyond. And in particular, for some of the provisions that have the potential to expire sometime during or at the end of this year, what those policies are, what dates to look for, what type of policy clarifications you need to be aware of in 2025 for your organizations. So I'd be remiss if I didn't address this deadline. February 10th, 2025 is an important deadline if your organization provides telehealth services and you want to provide input or feedback to CMS on the Medicare physician fee schedule and telehealth billing policy. The deadline to submit these requests for services to be included in the list of covered telehealth that would take effect if promulgated In 2026, that deadline is February 10th of 2025. We've got the link on this page. We'll send it out with the materials afterwards. But the significance of this is you're submitting requests for particular services that you want to ensure become or remain covered telehealth services under the Medicare program. Medicare will take that input, that feedback from the public for timely submissions, and then that will become what we see in the Federal Register's proposed rule in the summer. With that proposed rule, there's public feedback, public comment, and then we see a final rule in the fall to tell us what will take effect in 2026. What I have seen consistently in the last several years is CMS indicating that they received comments or feedback after the February 10th deadline, or there wasn't enough information, there wasn't enough data or support to justify the commenter's request. So keep all of that in mind here. I put a list of bulleted items that CMS likes to see. Those last couple, a detailed discussion for your proposal on what you want to see added or maintained on the list of covered telehealth services, an explanation of why this service either is like an office visit, why it takes the place of an in-person telehealth service, and just some of the things that CMS is looking for in those submissions. So keep that date in mind if it's important to your organization to provide feedback to CMS on the list of covered telehealth services for next year. So I'm not going to do a complete review of the telehealth policy from the 2025 Medicare physician fee schedule, but there are a couple of pieces that I wanted to just do a quick refresh because I think they kind of set the stage for some of the other legislation and the policy that we're going to be looking at and looking for and watching in 2025 and beyond. And in the Medicare physician fee schedule, this is an agency rule. And going back to how a bill becomes a law in your basic civics class, but the agencies are under the executive branch. So when this rule was created in November, we were under a different administration than we are today. And so that's important to keep in mind as we're kind of transitioning and shifting in how the current administration may view telehealth services and how that might be different from policy that went into effect in November. But the other thing that's important to keep in mind is that CMS, Centers for Medicare and Medicaid Services, and the Department of Health and Human Services, agencies of the executive branch of the government, they don't have the authority to change all telehealth policy. There are certain pieces of telehealth policy that are within their purview. There are certain pieces of telehealth policy that fall under the Social Security Act that cannot be changed by the agency. And for those pieces of those rules that are under the Social Security Act, it takes a literal act of Congress to extend, to make those permanent, or the other possibility is to revoke or rescind some of those telehealth policies. So this afternoon, we're going to distinguish between what policies and what pieces of telehealth live within the purview of Health and Human Services and CMS versus what we will be watching for in the next few weeks from some sort of federal legislation. So rewinding just a month or two, when we talked about the 2025 physician fee schedule for the Medicare program, one of the pieces of that program that CMS, that the Department of Health and Human Services have the authority to define, to redefine, or to refine is the definition of a telecommunications system. Under the Social Security Act, a law passed by Congress gave a very broad definition of telecommunications technology. They didn't define it within the statute, and Health and Human Services has the ability to refine over time what it considers to be a telecommunications system. Prior to the public health emergency, telecommunications system largely meant interactive, two-way, real-time audio and visual communication system, just like we're doing right now, right? It's two-way, I can speak out, you can speak in. It's real time. It's synchronous versus asynchronous. And we have the ability to communicate both through video and hear through audio. That's the way telehealth had historically been defined. During the public health emergency, telehealth use increased exponentially. And there are instances that either the provider or maybe a patient didn't have the ability to connect to a telehealth session with video. And so there were flexibilities during the public health emergency to expand the use of audio only telecommunication systems and to cover and pay for that as a telehealth service through Medicare. What we saw, or what we have been seeing since the federal COVID-19 public health emergency ended, is an extension of that flexibility while CMS continues to evaluate and consider whether and to what extent to permit audio only delivery of telehealth services. Last July, the proposed Medicare physician fee schedule suggested making audio only a permanent modality for telehealth visits in certain circumstances. And in the final rule, that was scaled back just a little bit. What we saw in the final rule is that audio only can continue to be offered as opposed to audio and visual when a patient is at home. And when a patient is at home and when audio only would be the format for the telecommunication, the telehealth visit, the distant site provider who is rendering that telehealth service must still have the ability to use video if able and if the patient wants to. But the patient, audio only would only be permitted if the patient cannot connect with video or does not consent to use video as part of that telehealth service. Consent here does not necessarily mean the patient is signing a consent form, the patient declining to connect with video, the patient saying, I don't want to, or I can't. That's sufficient. But these were the criteria to continue to use audio only. And then from a billing perspective, CMS developed policy where we have to identify when a telehealth service has been rendered as an audio only visit. Anytime I see that modifier, some sort of billing mechanism to identify a specific scenario, it always cues in my mind that may be a signal that CMS intends to pull these claims later by looking for this audio only modifier, like modifier 93, and look at these claims later on and make sure these criteria were met. The patient was at home. The distant site provider could have connected via video. The patient was not able to or did not consent to the use of video. Then December 31st, 2024 was an important date because congressionally, there have been extensions of certain flexibilities that took a literal act of Congress to extend after the public health emergency. And the reason they've required legislative action is because certain rules surrounding telehealth are in the Social Security Act, a law passed by Congress that can only be modified, only be extended, only be rescinded if Congress enacts legislation to do so. So while CMS has within its purview to define what constitutes an eligible distant site provider or audio-visual telecommunication technology, there are pieces that remain with the legislature, and we're dependent on the legislature to make these changes to continue these telehealth policies in 2025 and beyond. So I wanted to revisit those pieces that have been extended through acts of Congress, through legislation over the last couple of years, where we were before the PHE, where we were during the public health emergency, and the status as of today. So one of those pieces, one of those rules surrounding telehealth in the Medicare program is the definition of an originating site. So remember in telehealth, we have an originating site, which is where the patient is located. And then we have a distant site provider, the physician, the nurse practitioner, the nurse midwife who is remoting in, who is performing that telehealth visit with the patient. And prior to the COVID-19 public health emergency, what the Social Security Act said about originating sites is number one, you cannot bill a facility fee if the originating site is the patient's home. Now, what we mean by that, typically when we have a telehealth service, there's really two locations. I kind of think of a metropolitan area where we have a specialist who is providing a telehealth service to a rural geographic area, and the patient has presented to a rural health clinic or an FQHC. At the RHC, or the Federally Qualified Health Center, the originating site where the patient is located, they still have to check the patient in, get the patient to the room, connect the patient via telehealth. They have some overhead and costs and expenses that go into establishing that originating site for a telehealth visit. So the originating site code Q3014, hopefully I'm remembering that correctly, that's the originating site or the facility fee portion of a telehealth service. So what this said in the Social Security Act is if the patient is at home, you don't get to bill that originating site fee. That's in the Social Security Act. So CMS cannot change that through rulemaking. That's going to take an act of Congress. It's going to take legislation if providers are able to bill an originating site fee for the patient's home at any point. Now, the other piece of the originating site, there were only certain locations where the patient was physically situated that could serve as an originating site. And again, I'm talking prior to the COVID-19 public health emergency. Physician office, a critical access hospital, a rural health clinic, federally qualified health center, etc. There's something important that's missing here, and that was the patient's home. If you go down to the very bottom, with very, very limited exception, the patient's home was generally not an eligible originating site for telehealth services prior to the COVID-19 public health emergency. And I promise there's a reason I'm rewinding 5 years here to talk about pre-COVID rules. During the public health emergency, or I guess before I get to during the public health emergency, I want to zoom down into that, the patient's home really quickly. Because we say in paragraph, I'm going to call this Roman numeral 10, the home could be an eligible originating site in a very limited number of circumstances, paragraph 7. So here's what paragraph 7 said in the Social Security Act. When patients were being evaluated for the diagnosis or the treatment of a substance use disorder via telehealth, or for a mental or behavioral condition that co-occurs with substance use disorder. In that situation, down to paragraph 10, the patient could be at home for a telehealth service that could be payable by Medicare, but it was extremely limited. Outside of those exceptions, Medicare would not pay for a telehealth service for a patient who was at home. So let's fast forward a little bit to the public health emergency and some extensions by Congress after the official public health emergency ended. So during COVID, after COVID, which had the potential to expire and go away, January 1 of 2025. The home was made an eligible originating site for telehealth outside of that really narrow exception for substance use disorder treatment or mental behavioral health that co-occurs with substance use disorder. The patient's home was added as an eligible originating site. That was done by Congress through legislation during the public health emergency and extended each year up through December 31st of 2024. Now, at the end of 2024, there was a finance bill that had to be passed to prevent a government shutdown. And in that bill were telehealth policies that were critical to ensure provisions like this one, that the patient's home be an originating site for billing Medicare, extended past December 31st of 2024. And I remember watching this the week leading up to the end of the calendar year, not knowing for patients that next week whether they would be able to have their telehealth service or not. One bill that looked really promising would have extended this flexibility for 2 more years through the end of 2026, all of 25, all of 26. At the 11th hour, that bill was rejected. Back to the drawing board. The bill that ended up getting passed was an extension, a really short-term extension of this provision, allowing the patient's home to be an eligible originating site for Medicare telehealth services through March 31st of 2025. So that's where we are today. So we sit here towards the end of January 2025. A patient's home will continue to be an eligible originating site through March 31st, 2025. The reason for that, I think, is particularly because this year involved a change in administration. Rather than extending that policy through the entire calendar year, the thought, I think, in that finance bill at the end of 2024 was, let's wait. Let's let the new administration come in January, let them assess the landscape of all of the rules and all of the policies and all of the legislation, and then move forward for the remainder of 2025 with the policies that they want to carry out. With that, I expect as we get closer to March of 2025, this will be a last minute exercise yet again, not knowing on April 1st what the outcome to this telehealth policy might be. And what the outcome might be, there's kind of 3 possibilities. Making the patient's home an eligible originating site for Medicare telehealth billing. It could be extended. Likely, that's through the end of the calendar year, maybe a 2-year extension. It could be made permanent. I might be surprised. I don't anticipate that's going to be part of this kind of last minute financial package in March, but that's a possibility. Or worst case scenario for the patients and the providers who have been relying on telehealth for the last 5 years, it's possible that this provision expire and not be extended any further through legislation, which would mean April 1st, 2025, we would revert to where we were prior to the COVID-19 public health emergency, which did not allow the patient's home to be an eligible originating site, except for very limited exception, like the evaluation or treatment of substance use disorder or mental behavioral health conditions that co-occur with substance use disorder. Very closely related to the location that the patient is physically presenting from during a telehealth service is the rural, I call it the rural geographic area requirement. That's kind of my shorthand for really several components. Sorry, I'm skipping ahead here. For several components, several requirements. One of those is that the patient is in a rural geographic area, a healthcare provider shortage area, an area outside of a metropolitan statistical area. That was the rule prior to the COVID-19 public health emergency. Kind of coinciding with flexibility saying the patient doesn't have to physically present to the rural health clinic, to the physician's office, to the critical access hospital. The patient could join from home, Congress said during the public health emergency. Congress also said, we will open this up geographically so that the patient can be located anywhere in the United States when the telehealth service is rendered. And that flexibility continued through December 31st, 2024. And I have a little asterisk here because state licensing rules still apply, which typically say that the provider has to be licensed in the state where the patient is located. That's a state licensure issue, but this provision that the patient could be located anywhere for Medicare payment purposes was just a payment issue to open up that flexibility. So the current status of the rural geographic area requirement, that remains an option and it remains flexible through March 31st of 2025. Just like home as an eligible originating site, I expect that this is going to be potentially part of the same kind of last minute financial package, whatever Congress reaches by March 31st, 2025, you're going to see in the headlines that they're trying to reach a deal to avoid a government shutdown, because what happened at the end of December was just a temporary financial package to get us through the change of administration. Let the new Congress, let the new administration come in, and what they will be working on in March will be the full financial package for the year. Just like home as an eligible originating site, couple possible outcomes. The ability for the patient to be anywhere in the United States when the telehealth service is rendered, that could be extended, likely through the end of the year, maybe longer. It could be made permanent. I don't anticipate that's likely going to happen by March 31st, or it could be allowed to expire, so that on April 1st, 2025, we would be back to the requirement that the patient is in a rural area outside of a metropolitan statistical area and or within a healthcare provider shortage area. Now, I have distant site providers, but I changed the heading over on the side just a little bit. This is policy that is influenced by Congress, but not necessarily dependent on an act of Congress and legislation. And I say that because prior to the COVID-19 public health emergency, Health and Human Services, CMS, got to decide the list of eligible distant site providers of telehealth services. That's not a list that is delineated in the Social Security Act. CMS has the ability to define this list. So here's what we were looking at prior to the COVID-19 public health emergency: physicians, nurse practitioners, physician assistants, etc. There are a couple really important bullet points that are missing from the bottom of this list prior to the COVID-19 public health emergency. Prior to the COVID-19 public health emergency, RHCs, FQHCs, critical access hospitals, community mental health centers were not on CMS's list of eligible distant site providers and billers for telehealth services. And for that reason, they were not allowed to bill as distant site providers of telehealth services. This is prior to the public health emergency. Enter COVID-19. During the public health emergency, several different disciplines, I apologize, I did not mean to leave physical, occupational, and speech language pathologists out when I said a few disciplines were missing from the previous list. But during COVID-19, there were incremental policy changes to add to that list from CMS. We added physical and occupational therapy, speech language pathologists to the list of eligible distant site providers during the public health emergency. RHCs, FQHCs, and critical access hospitals. That was part of CMS policy, but I say this is kind of a combination of agency policy and legislation because when the public health emergency ended, Congress enacted legislation as part of these annual financial packages to require CMS to continue to cover and pay for these disciplines as distant site providers of telehealth services, with a few exceptions. Critical access hospitals didn't make it into the final legislation. Their ability to deliver and bill for telehealth services as a distant site provider ended when the public health emergency ended. But RHCs, FQHCs, PTs, OTs, speech language pathologists, they were able to continue to provide and bill telehealth services through the end of December 31st, 2024. So the end of the year, we waited. What was going to happen to PT, OT, speech language pathologists, RHCs, FQHCs, January 1 of 2025. The extension that was passed says all providers who are eligible to bill for Medicare can continue to for professional services can continue to do so through March 31st of 2025. Just like our last couple of provisions, I'm gonna wait and see what kind of finance bill will Congress continue to mandate to CMS to continue to cover these disciplines of providers as eligible distant site providers of telehealth services. If not, it doesn't necessarily mean they will not be able to deliver telehealth services. Whether they will be able to April 1, 2025 and beyond will be up to CMS to adopt through policy because CMS has that authority. But what CMS cannot do, if Congress says you must cover RHCs and FQHCs and therapy disciplines as distant site providers, CMS cannot refuse to cover and pay for those disciplines as distant site providers. They can be more expansive, but not more restrictive. Okay, so getting us through March 31st of 2025. Now I want to talk about a rule that has run really in parallel with a lot of these flexibilities under the Medicare program, yet separate in the sense that it's an entirely different agency that dictates these rules. These are when we can provide telehealth services and bill and be paid for them. Now we're going to talk a little bit about what can we do during a telehealth session under the Drug Enforcement Administration and their rules for the prescription of controlled substances during a telehealth visit. Now I have, and this will be available on the slides, the materials that we send out afterwards. These are hyperlinks so that you can pull up these rules and see them. There is a lot going on in the world of the DEA with rulemaking, particularly when it comes to telehealth services right now. Prior to some of the COVID-19 flexibilities, there was legislation called the Ryan-Haidt Act. And you may see that when you talk about the DEA and prescriptions via telehealth. But the Ryan-Haidt Act sought to ensure that providers who were seeing patients to prescribe controlled substances had at least one in-person face-to-face visit with that patient before prescribing controlled substances. That rule, that requirement, that restriction was lifted. It was relaxed during the COVID-19 public health emergency, and we've had a series of extensions to that since then. These were set to expire at the end of 2024, separate from our legislation on just basic telehealth rules, but these were kind of running in parallel. So for the third time, the DEA extended its flexibilities that would permit providers to prescribe controlled substances during a telehealth encounter, even if the prescribing professional has not had an in-person medical evaluation of the patient. I should have put an asterisk on this slide. And the asterisk is we still have state laws, every state providers would need to defer to determine if under that state's licensing laws, can a provider develop a provider-patient relationship with a patient under the state laws, and can the provider prescribe medications during a telehealth visit for that kind of first encounter with the patient. So this is only talking about the DEA rules. It would also allow the prescription of controlled substances with audio, video, telemedicine encounters, which had not always been permitted prior to the COVID-19 public health emergency. So that third extension is going to get us into 2025. And right before, actually, this was January 16th, I believe, right before the inauguration, the DEA issued several different proposed rules. When we send out these materials, each of these images has a hyperlink that will take you to the full proposed rule if you want to dive into these a little bit more. But I wanted to share what these proposed rules are and what they would do once and if they are considered by the DEA. So one of these three new rules that are being proposed would ensure that patients have access to telehealth services for medical care and prescriptions. They don't apply if the patient has already been seen in person by a medical provider. So these are really addressing what can be done via telehealth with respect to prescribing controlled substances when there has not been an in-person medical evaluation by the prescribing professional. The second of three proposed rules by the DEA addresses, I'm not even going to try to pronounce it, I know I will mispronounce it, but the medication that helps with substance use disorders, opioid use disorders, when they are prescribed and managed via telehealth encounters. It would allow patients to have remote access to a prescription for this medication to treat opioid use disorder. The patient can receive up to a 6-month supply through a telephone consultation with a provider. Because if I rewind one slide, I said audio visual. This one would allow that prescription as an audio only encounter with the medical provider. Beyond that 6-month supply, the patient would have to see the provider, and they use in person because in person means physically situated together, where face-to-face can be the audio-visual portion of a telehealth visit. In person is meaning truly that traditional form of a physically present service between the provider and the patient. And the third of the DEA rules that were proposed just a week or so ago deals with a special registration requirement for providers who would be seeing patients and prescribing controlled substances potentially through a telehealth visit. So this would involve, without ever having seen the patient in person, remember, the DEA said these three rules do not apply, providers, if you have had an in-person encounter with this patient. This is really trying to address rules, restrictions, guardrails for circumstances where there's a prescription of controlled substances without an initiating in-person visit with the provider. This special registration process is just that. Providers would register with the DEA and be eligible to prescribe certain controlled substances via telehealth in the absence of an initial in-person visit. Let me back up one piece here that I want to highlight on this proposed rule is it would also be for online platforms. And for the first time, they would be required to register with the DEA as well if they are going to facilitate the prescription of controlled substances. And again, as we send these out, each of those images of sort of the press releases for these proposed rules will have hyperlinks to take you to the full rule if you want to learn more about those. But I want to shift gears a little bit because those 3 proposed rules from the DEA were announced January 16th, I believe, of this year. Just a few days later, we had the inauguration and the change in administration. So now we're kind of trying to figure out what is the new administration's policy? How do they view telehealth that might inform what's going to happen April 1 of 2025? And will Congress extend, make permanent, or allow some of these telehealth flexibilities to expire? What might this look like as the agencies, which are part of the executive branch, kind of part of the new administration, evaluates telehealth services for controlled substances? So there's a few things I think are informative. It's always a question. There's always so many political dynamics, and this is not intended to be a political discussion. But I think looking back at the last 12 or 24 months, there are some signs or clues on the direction we may be headed with some of these policies, legislation, and rulemaking in 2025. At least this time last year, the expansion of telehealth seemed to be a bipartisan issue. It seemed to be something that both Republicans and Democrats supported when they were considering policy. There was some hesitation from a program integrity standpoint and a spending standpoint. And part of the reason these flexibilities have not been made permanent since the end of the public health emergency has been Congress wanting to do some more studies and some more evaluation of program integrity guardrails and spending implications of expanding telehealth access. So I think that's 2 things we're going to see the administration considering. The desire to expand access balanced against the impact on spending. Something that has also happened in the last 10 days or so are a series of executive orders, not necessarily specific to healthcare, but that touch in the healthcare space and have the potential to affect telehealth services. One of those, for example, was an executive order to remove barriers on the implementation of AI across government healthcare programs. And of course, we know AI in healthcare is having growing and significant implications. So those DEA rules we just talked about, just a few days later, one of the executive orders was to suspend any new proposed rules from being released and to pause on any final rules being announced and released. So as of today, just 10, 12 days later, those DEA proposed rules are on pause in the sense that if it were time to release a final rule, the agency wouldn't be doing that. Now, we can still submit public comments to those proposed rules, but we're not going to see those rules become finalized unless and until the new administration gives the green light and the go ahead to do that. The thought is that's part of the new administration's, again, kind of pausing, getting the lay of the land and the landscape to see what rules are out there, what policies are out there, what deadlines are out there, what's the current spending. We've got a huge financial package coming up in March, and to kind of give them an opportunity to review and lead the agencies in the direction that the new administration wants to go. There is a really good, I've got a link here when we send the materials out from ctel.org, and it's kind of what happens with telehealth in 2025 under the new administration, sort of assessing a series of executive orders and what that means for telehealth specifically. So I think that's a great resource if you want to kind of have some evening or weekend reading materials. But I also think it's interesting coming into some of these really critical deadlines for telehealth policy. At the same time, we have a change in administration. It's very reminiscent to me of the January to March, May period of 2020, when telehealth rules during really the height of the COVID-19 public health emergency, we're changing what felt like on a daily basis. So I want to kind of give you a then and now sort of comparison on your, oh my goodness, is this your left? I'm trying to do the teacher's rule and reverse my right and left. So on the left-hand side, we have President Donald Trump expanding access to telehealth services. And if you look at the date, this was in 2020, acknowledging how critical it was at that time to make sure telehealth services were available. And then while Donald Trump, the new administration, has not specifically addressed telehealth, at least that I've seen quite yet, we do see policies that seem almost contradictory to this remote to a telehealth kind of concept, like bringing federal workers back into the office. So it kind of remains to be seen. We're going to wait over the next couple of weeks and see, what kind of policies formulate from the new administration to get a sense of what might happen to telehealth in 2025 and beyond. So for this year, telehealth in 2025, kind of rounding this out here, March 31st of 2025 is really our next extremely critical date for telehealth policy, in the sense that Congress will really dictate in the next financial package whether they will extend, make permanent, or allow some critical telehealth policy to expire as of April 1, 2025. If I had a crystal ball, I wish I did, but I anticipate we will see an extension, but not necessarily making those policies permanent. How long we extend those, how quickly we're going to be in the same boat of worrying whether the next week we'll have access and coverage and payment for those services, yet to be seen. But typically, because it's part of a finance bill that would dictate finances for this fiscal year, you would expect that to at least go through the end of the government's fiscal year, but typically they go through the end of the calendar year. So fingers crossed. I think there's the potential on April 1 that we'll see an extension through the end of the year. So there's some things to keep your eye on. I just said March 31st is our first critical deadline, but let me reverse that just a little bit. February 10th is still an important deadline to get your feedback to CMS on telehealth services that you want to see eligible for telehealth coverage and payment in the Medicare program. March 31st, important deadline for congressional action that will tell us whether and how much longer we're able to exercise flexibility surrounding patients' home as an eligible originating site and the geographic areas where a patient can be when telehealth services are rendered. Then we're going to be looking at the impact of any of the freezes on executive agency rulemaking and how that impacts the ability or inability to prescribe controlled substances via a telehealth service. However, for that freeze, we currently, through the third extension by the DEA, have through the end of this calendar year. So I anticipate the administration's freeze on rulemaking will be lifted once kind of the dust sort of settles as they've taken over the administration. And then we'll have final rulemaking from the DEA at some point this calendar year to tell us what happens January 1 of 26 with respect to controlled substances via telehealth in 2026 and beyond. So Molly, I'm going to pause there and see if we've got any questions that we want to try to tackle in our last couple of minutes here.
We actually do. I think there's one that would be a little bit helpful really quickly, is the medication for addiction treatment, substance use treatment. Was that final or proposed?
That's a proposed rule. I'm going to quickly go back to a slide. So I apologize for making everybody dizzy here. So this is a proposed rule. And because it was proposed January 16th of 2025 by the DEA, today the new administration has placed a freeze on agencies evaluating any proposed rules. So moving this forward and reviewing comments and moving it to a final rule is on hold, although it's still very, very early in the rulemaking process. There should still be an ability to submit public comment on it. And then once that freeze is lifted, agencies are again able to evaluate proposed rules or final rules. Then this can continue through the rulemaking process.
Is there any guidance? It looks like there was a link shared to me that was for the 17th on that rule. And I think we can include it with our final, we can review a little bit more offline, Rochelle, and maybe add to that.
Do you mean to the proposed rule, Molly?
Yeah.
Yes, you bet. When we send these materials out, if you see when I'm hovering here, when we send the materials out, if you click this image, it will take you to that proposed rule to learn more.
Let me scroll back. An early question was, what is defined as home? For example, consumer or the patient is sitting in their car, either parked off site or in another location.
Yeah, that's a great question. And one of the, I think, helpful flexibilities that we had in combination with the patient's home, rulemaking that was extended to say, actually, any place where the patient is located within the United States. In 2023 or 24, a new place of service code was created for telehealth services. Because previously, home wasn't even allowed as an eligible originating site. So we really didn't have to grapple with that question of whether patient Rochelle is in her home or in the parking lot of the grocery store or at the library during a telehealth visit, because those weren't allowed eligible originating sites at that time. So place of service code 02 had been in place to identify that this was a telehealth service. That place of service code was sort of bifurcated into two. Now we have place of service 02 for a telehealth visit to a patient somewhere other than the patient's home. And then now we have place of service code 10 to identify a telehealth visit to a patient who is at home. Place of service 10 has a definition that includes temporary sites where the patient may be presenting for a telehealth visit, like the parking lot of the grocery store.
Okay. Sorry, I'm scrolling. Do you happen to know if Missouri and Kansas Medicaid are accepting 93 and FQ modifiers?
That's a great question. I've tried to keep track of the Medicaid agency's policies since the end of the COVID-19 public health emergency, and not a whole lot has changed. But I'll take that as a follow-up, Molly, for after the session to go see what today's policy on the 93 and the FQ modifiers are. So those are the modifiers for an audio-only service under the Medicaid program.
Okay. And so for clarification, physicians can perform audio-only services when their patient does not have access to video for any diagnosis deemed clinically appropriate for the audio-only visit until March 31st.
That's a great question too, and I'm so glad that question was asked. What I'll do in our follow-up is include a link to the 2025 Medicare physician fee schedule covered list of covered telehealth services. This list gets published in Excel format every year, including this year. And in this list, it identifies every CPT or every HCPCS code that Medicare has approved and said, this meets criteria to be a telehealth service. You can bill for this via telehealth. On that list, there are certain codes that allow the use of audio only that says, yes, you can render this particular item or service using audio only. If yes, then the rule that as long as the physician or the other distant site provider could intervene with video, but the patient cannot or does not consent to, would allow the provider to continue with that service as an audio only service.
Okay. We have a few more minutes, just a couple minutes. There was more detail with that question, but I think it'll probably be best that we walk it through in our follow-up. Does CMS still allow audio video visits to be performed in the inpatient setting, where both physician and patient are located in the hospital?
Yeah, so great question. I believe so. I'll take that one as a follow-up as well, and just make sure that the hospital CPT code, your 99221 through 99333, would probably be your most common ones. On the Excel file, the list of covered telehealth services for 2025 say, yes, this is one of the covered telehealth services through which audio only can be used to deliver that service and bill and be paid for that service.
Okay, well, we are nearing the top of the hour. We have quite a few questions in the chat, Rochelle. We have notated all of them. We will be answering them individually and then offering up links, any clarification or updates or confirmation that might be needed. And we will give the resource with each response that we provide. So give us a little bit of time to get that to you, but we will be getting that turned in very quickly. I did include our regional survey link in the chat earlier. For those of you that joined later, I am going to put it in the chat again. The HTRC launched our regional telehealth use assessment, and I want to make sure that everybody has an opportunity to answer it because it helps inform on our education outreach and any resources that we may provide. So thank you again for joining today. I appreciate everybody's questions. We will be putting these together, as I said, and getting them sent out to you as soon as possible. So thank you and have a great week.